Hello, everyone. Welcome to episode 3 in our Return to Performance programming series. My name is Tony Ambler-Wright, and I'm joined by my friend and colleague, Ken Miller. Ken, how you doing, buddy?
I am good, Tony. How you doing, bud?
Doing fantastic, thanks.
Yeah.
Excited to get back on the line with you and talk about some Return to Performance programming.
Always.
So for those of you who joined us last week, we discussed return to performance programming for the foot and ankle complex. In this episode, we're going to focus on the knee. Basically what we'll do is we'll follow a similar format to what we did last week, where we'll discuss some common knee injuries. We'll discuss, what does full recovery actually mean? What is the goal? And then we'll spend, our hope is to spend the majority of the time discussing programming options for individuals who are coming back from knee injuries. And then prior to getting into all of that, though, we will address some questions that we received from last week's episode. And on that note, if any questions arise as you guys are tuning in, please feel free to leave them in the comments section below. And if we can't address them in real time, we'll address them in subsequent episodes. So with that, Ken, do you have anything you want to touch on before we get going?
I believe we had a question, if we're going to address questions right now, on foot orthotics, right? As far as foot orthotics go, just to touch on that, it's one of those things where if someone needs it to feel better and they move better, they feel a significant difference in how they feel, not just in the foot and the ankle, but also the knee and or the hip by changing the mechanics of the foot. And if the orthotics help with better foot positioning, so with every step, every stride that they take, whether they're walking, running, and jogging, then by all means, it's one of those things that if it's already in play and in the picture, then keep on going with it. But when it comes to program design, when I'm working with somebody and I look at their shoe, one of the things I'll do is I'll look at the bottom of the shoe. I'll look at wear patterns. Maybe one foot's interacting with the ground a little bit differently than the other. But I'll also ask if they've got an insert in their shoe or whatever footwear that they're using on their day to day. And a lot of times they'll volunteer that, I do have something that does help out. But I'm going to take that into consideration and look at the assessments that I use for, what's happening, the feet turning out, knees coming in, low back arch, whatever comes up from the assessment. And I'll see if there's another way to get the body to move better without the help of the orthotic. So, but if there are things happening with the foot, let's say like, a real foot arch collapse during gait, those are the things that I'll try and address during their strengthening program. But there are times when I'll have to refer out to, a podiatrist or a physical therapist as far as what's happening in the foot that I don't have the scope of practice to address at that point in time. So I'm for it if it helps, and if it helps with our workouts and how we do other things, especially with performance. But if there is something that can be done and implemented from a corrective exercise or a strength conditioning strategy, I'll look at ways to strengthen the deficits that might be contributing to why somebody thinks they might need an orthotic.
Yep, right on. Perfect. I agree wholeheartedly. So I don't have much else to add there. Nice work.
Yeah.
So, I think that was the only question we got related to foot and ankle was on the orthotic. But certainly, if anything else comes up, feel free to continue to ask. All right. So let's get into the knee. So the first thing we'll cover are just what are some of the common injuries that you may encounter, or what are some of the common injuries that clients may be coming back from that you might encounter, whether you're working more in the performance sector or fitness environment. Very common to see anterior knee pain. So patellar tendinopathies, also known as jumper's knee. So individuals who are involved in a lot of jumping, cutting, activities where they have to decelerate quickly may experience anterior knee pain and increased stress to that patellar tendon. In the youth athlete, something that you might encounter, which is very similar, is Osgood-Schlatters, where basically there's inflammation to the area where the patellar tendon attaches to the tibia. And typically when you're looking at the youth athlete, that Osgood-Schlatters is more of a repetitive stress and overuse type of injury that can resolve over time, but there are different ways to handle that. Some of which we'll get into when we discuss the programming. Let's see, patellofemoral pain syndrome, really common one, where there's a malalignment or tracking issue with the patella, and how it interacts with the femur and the tibia, and that creates stress underneath the kneecap that leads to pain and inflammation. IT band friction syndrome is another one that's pretty common. And then when we look at some of the other structures of the knee, you might see things like meniscal tears, and there's some differences there. You've got acute meniscal tears, which are caused by some sort of incident, and then there's also degenerative changes that can occur to a meniscus, to the menisci over time. And so when you look at individuals, even starting as young as 40 years of age on up, it's very common for individuals to have some sort of degenerative tears or changes to the menisci. And many times they're asymptomatic and people wouldn't even know they were there. But it is common to see that. And then probably, the biggest elephant in the room, and the one that, the thing that most people are concerned with as it relates to the knee is, ligamentous injury. And, for example, ACL, anterior cruciate ligament injury, being the one that everybody's concerned with, and really that can create the most problems, not only acutely, but from a long-term standpoint, when you look at the effects of returning from that type of injury. And the psychological impact, the musculoskeletal impact later on in life can be pretty profound. So we'll talk quite a bit about ACLs and what you want to look for from a return to performance standpoint, as well as in the healthy population, what can you do? What are some best practices and recommendations from an injury prevention programming standpoint as well?
Right. And all of these things that you mentioned, Tony, these things within, again, following scope of practice, all of these things need to be diagnosed by a physician or a physical therapist, somebody who's qualified to do all the tests to kind of rule out one thing or the other. So as much as we can look at movement patterns and, it's just like claws, nails on a chalkboard when somebody watches someone's movement pattern. It's like, hey, I think you've got ACL issues. Well, that goes well beyond, the scope of practice. So in the workshops that we teach, when we're going over movement assessments and observations and watching these compensation patterns, somebody, they're not moving well when that knee's coming in and they've got excessive forward lean and the feet's turning out. That's not a cause to say, well, you have lateral knee pain, or you can't assume that someone's going to have. Somebody can move poorly their whole lives and not experience 1 ounce of pain. So, and that's where when we talk about return to performance, it's not just about all these things that have been listed with possible meniscus issues, ACL, patellofemoral, IT band friction syndrome. They can have, if you've ever run a half marathon or a full marathon and you're running behind people, and believe you me, when I've run, I'm behind a lot of people. So I am watching, the leg whip, Tony, you know what I'm talking about? Where they just swing that foot around. They can't get a good knee drive, and that foot is definitely just whipping around, almost like you're doing egg beaters in a pool. So someone can move like that. They can run a million or 100 races, and they may not experience anything, right? And that's where combining the assessments along with what has been diagnosed, then you can have a better understanding of what can be done or should be done from a personal trainer or strength coach standpoint. Because like what you said, Tony, when you're talking about the difference between the rehab process for a meniscus tear versus an ACL, you're talking anywhere from the difference between 3 to 4 months to 9 to 12 months between the two. Mm-hmm. And that's definitely going to have to come under the guidance of the physical therapist to kind of, take your hand and figure out, okay, well, what are the no-nos? What are the things we should not do at this point in time? And again, based on timeline, you're going to look at, okay, we need to achieve 40 degrees by this time, 60 degrees by this time, 80 degrees by that time. So, all good stuff, but we as personal trainers and strength coaches, someone can be just, point by point describing any one of these syndromes exactly, but we're still not in a position to say that's what you got. Right.
Yeah. But fantastic points.
Yeah. Yeah.
Just reinforces the, what we discussed in the previous installments where, you've got to look at this as you're part of a team, and within that team, there's a hierarchy of sorts and a scope of practice that needs to be minded and respected. So,
right.
Yeah, great stuff. With that said, just to reinforce what we've discussed before is that, what Ken and I are referring to when it comes to the programming and some of the different considerations, we're certainly laying the groundwork and providing you some context around the different types of knee injuries and some of the things that are done maybe during the rehab phases. But when we're discussing our role, the programming options, and some of the things to look for, we definitely want to reinforce that we're discussing beyond that acute rehabilitative phase once the physical therapist or physician has really cleared the individual to be able to begin working with the strength and conditioning coach or personal trainer.
Right.
Something to be said too about the injuries that we went through, even though they're all looking at different structures and have their own set of symptoms. The underlying theme here, and we discussed this as well with the ankle last week, is that there's a certain level of biomechanical risk factor. There are certain levels of biomechanical risk factors associated with some of these common injuries. And, that's important for us on the strength and conditioning personal trainer side, as Ken alluded to, when we perform movement assessments and we're observing how our clients interact and move during certain activities, there are certain things that we want to be aware of that could potentially increase the risk of, let's say, a re-injury, or over time, if left unchecked, could increase the susceptibility of some type of non-contact injury scenario. When it comes to the ACL in particular, there are certain intrinsic factors that can influence the injury to the ACL. Many of those we can't do a whole lot about. And so, quite a bit of the focus when it comes to programming and prevention is on extrinsic factors. So looking at strength, ratios, biomechanics, neuromuscular control, and so forth. Those are all things that can be influenced with a training program. Coaching and feedback is another big one. So, we'll discuss that more when we get into the programming. When it comes to rate and frequency, the most commonly injured joint in adolescent athletes is the knee. And when you look at, let's say, the high school athlete population, the prep athlete, 60% of injuries in that population occur to the knee. So,
right.
Very, very common, something that you're likely to encounter, but with good programming can either be prevented or the risk reduced. And then as you might be assisting somebody return to full performance from something like this, then, there are certain best practices that we can follow to ensure that they come back as strong or stronger than they were before.
Definitely. And just anecdotally, with having worked 2 years in a physical therapy clinic, I would say a strong majority of the kids, when I just lump them up in the high school, between high school and junior high kids, it was a lot related to the knee as far as what I had to work with. You know, you have your ACLs, you have your IT band friction syndrome, and you know your patellofemoral, basically everything you've listed out as far as what somebody might experience. And you know, you get your share of ankle sprains, but you know, ankle sprains, you know, again, flashback of last week, you know, a lot of times, unless it's major, it will resolve itself. But when it comes to the knee, you wind up, you know, the knee winds up being one of those areas where you're chasing symptoms, right? It just happened to be that the knee is where your body decided to break down, and we'll get into the hip and the ankle and its relationship to the knee in a little bit, but you know, and this is where a lot of parents get concerned, is when their child gets hurt, and then they get hurt again, and then they get hurt again, and then now it's like, okay, now it's more than just playing soccer, playing softball, you know, football, which the first incident may have been a contact issue, but when it happened again, they just happened to be doing a drill, you know. So as these injuries happen, you know, especially in that adolescent or junior high school, you know, prep age, it is one of those things where their body's growing. Again, you mentioned Osgood-Schlatters, their body's changing. Just, you know, when we talk about intrinsic factors, their body's changing, and then there's all this stress happening at the same time the body is changing. So as you go through your growth spurts between, you know, muscular and bone growth,
hormonal changes,
all of that, you know, there's a lot of, they're still learning, you know, they're like puppies growing into their big paws, and that's what's happening at this age range, to where again, working on those other factors, flexibility, range of motion, stability, as well as strength and power production and reduction feed into all of that, you know, when we talk about rate and frequency, especially in that adolescent age.
Yeah, no doubt. So, you know, with that, what does full recovery mean? You know, we talked about this a little bit last week as well, but, you know, typically it means restoring full range of motion to the affected areas, as well as, you know, areas of influence. So as Ken mentioned, you know, the knee it's at the mercy of the foot, ankle, and the hip. And so even though the symptoms and the site of injury is at the knee, often that's due to the interactions it has, or the influence rather, of the hip and the ankle on the knee joint during movement. Looking at reestablishing and improving stability, strength, power production, force reduction, neuromuscular control, conditioning, and sport specific activity skills. And then, you know, in order to establish whether somebody has made that full recovery, you know, that's where, you know, your functional performance testing may come in to determine symmetries and balance, as well as readiness. And then, you know, there are certain psychological assessments that can be done as well, to determine if the individual has, you know, full confidence and in their return to performance abilities. So, which is going to be critically important. From a reconditioning standpoint, as we go through this, again, the goal is to establish and or reestablish dynamic neuromuscular control and coordination, restore isolated strength. Endurance is a big one, power, and reintegrate that into total body functional patterns and activities. And then, you know, what we'll talk about from a programming standpoint may start off with more of a looking at it from more of a corrective exercise, through more of a corrective exercise lens, maybe more therapeutic in a sense, and then progressing into reconditioning, conditioning, and more dynamic exercises and activities. Ken, anything you want to add in there?
No, I mean, that's a pretty thorough explanation. And I think the biggest point that when it comes to return to performance that gets missed is that confidence level to, like, if you're in a varsity sport, you're in a varsity sport, right? So as a junior or senior in high school, if you're at the highest level that you can compete in high school, you have to know that if I'm going to step on the field and if I'm the receiver and you're asking me to go down the middle, right, and catch a ball there, I have to know that I can stop, turn, catch the ball, and take a hit. If I am hesitant at all, I'm going to get alligator arms. I'm not going to extend, and that's going to affect how I play, or how that the overall play with the team is going to come to fruition. So if I'm not confident in making that stop, pivot, turn, catch, any one of those steps within that sequence of play, that slight hesitation, that having to stop and decelerate more than what you would need to can add to more knee stress from that vantage point. But it's also going to affect, how well you actually perform. So if you're going out there and let's say you've got the check on all the boxes from a physical therapy, strength conditioning, athletic trainer standpoint, this person's body is ready to go, but psychologically, you don't have confidence in the knee to make that play, then you're going to play scared. And it's when you hesitate, when you're more susceptible, from an injury standpoint. So not just the physical side, but when we talk to performance, can you actually perform with everything that you've worked for? So it's not just about flexibility, range of motion, power, production, reduction, metabolic conditioning, but also can you, with confidence, get back onto the field of play? And that's the one thing we have to, when it comes to programming, like you talked about, are we building in that psychological aspect? Like, you can run, you can stop, you can turn, and see, nothing's happening to you. You're okay. You're 100% okay. You're going to take the hit, or things are going to happen, but physically, you're strong, and you have to know that.
Yeah, absolutely. Thought you were going to throw another pivot out there. Friends reference. Pivot.
That's it.
Might be showing my age a little bit, but
yeah, I was gonna say, I got to watch Friends.
Good episode there for those of you who haven't seen it. Cool. Yeah, with that, let's talk about some considerations as we get into the programming elements as you work with somebody who might be returning from a knee injury. So with musculoskeletal injuries, the number one risk factor for re-injury is previous injury. So that's something to be aware of, that, somebody getting hurt once is going to predispose them or increase the likelihood that they may get re-injured. So something to be aware of there. The other thing is looking at symmetry. So asymmetries in the body are another big risk factor potentially for non-contact musculoskeletal pain and injury. And we'll talk a little bit more about this with some of the different tests that your clients or athletes might go through. But generally speaking, if there's a greater than 10% difference between the injured side and the uninvolved side, then that's something that's a gap that you want to close down as quickly and as much as you can. As you get over that greater than 10% difference, then the risk of injury is going to go up. Things that you may also have to consider, again, swelling and inflammation, pain, range of motion. So as you continue to work with your clients, areas that you want to keep an eye on from a range of motion standpoint would basically start down at the foot and ankle. So big toe extension, for example, the extension of the first MTP. If there isn't adequate mobility at the big toe, then during running, lunging, cutting, stepping patterns, that can exacerbate over pronation at the foot and ankle, which is then going to cause some obligatory movement at the knee that could potentially increase stress to the injured areas. Ankle dorsiflexion is another big one. Knee extension. So when we look at knee extension from, let's say, a 90-90 position, we want anywhere from 0 to 20 degrees on that. So basically where the knee is almost fully extended to fully extended. Knee flexion is another one. Total hip rotation. So some good evidence that correlates total hip rotation range of motion with knee injury risk and stress. of the two, internal or external rotation, internal rotation is going to be one that we want to really focus on and make sure our client possesses adequate range of motion there. And then hip abduction is another one. So, if we look at knee extension, that's looking at the short head of the biceps femoris, which we talked about that last week with the ankle. If that muscle is tight and overactive, it can create more external rotation and abduction of the tibia relative to the femur, and that's going to put more stress on the knee joint. If we look at hip internal rotation, if the hip can't internally rotate during movement, then that's going to increase adduction forces on the knee. Excuse me, abduction forces on the knee is basically going to cause the femur to adduct more. And then when you look at, I guess another one would be hip extension would be important, and then hip abduction. If there's a limitation in hip abduction, then that's going to increase the likelihood of the femur adducting, which is going to put more stress on the knee. So all of these are important to look at and monitor as you're working with clients who've experienced knee injury. All these mobility assessments that I just highlighted are part of our new CES course. So we updated the CES where previously range of motion assessments were addressed using a goniometer, and there was also some manual muscle testing, and we've since replaced those with these active mobility assessments so they can be utilized by a wider range of professionals and in a variety of different environments. So those are all assessments and mobility tests that you want to do to not only see where your client's at as they begin to work with you, but also track progress over time.
Exactly. Yep. And those assessments that you're talking about, they're not complicated. I mean, they're easy to implement, and to your point, Tony, again, looking at the factors that go into how or why somebody may get injured, one, previous injury, and then bilateral asymmetry. So just performing these assessments, you look at, okay, if I'm laying on the ground and I'm legs straight out, and I'm looking at hip internal, external rotation on the right side, hip internal, external on the left side, and definitely if one foot turns in more than the other, then I can say to some confidence that, okay, well, maybe we need to look at your hip external rotators on that right side, because you're able to turn that left side in noticeably more than the other side. And that's just looking at one assessment as far as hip internal rotation, and to that 90-90, straighten out one knee, straighten out the other. Where do you get more range of motion? If you've got just a noticeable difference between the two, then that gives you some insight, okay, on what side needs more love as far as a corrective strategy goes, to say it simply. Yeah.
Perfect.
So it doesn't have to be complicated.
Not at all. No, and these tests, they take just a matter of minutes once you get familiar with the process and the setup and what you're looking for. So yeah, very easy to implement, as Ken mentioned. From a strength and stability perspective, some of the same muscles that we talked about last week, ankle inverters. So again, we want to limit lower extremity pronation. If there's more pronation or if there's a difficulty controlling pronation, rather, we want to make sure that there's good strength in the posterior tibialis, anterior tibialis, ankle dorsiflexors, also the tibial internal rotators. So again, when you look at, a more risky position for the knee is where the tibia relative to the femur externally rotates and abducts. And so that can be allowed by relative weakness in the tibial internal rotators. The semitendinosus, membranosus, gracilis, popliteus, sartorius, basically that whole pes anserine complex. We want to make sure that there's adequate strength in those muscles to be able to control that rotation, that external rotation. The quadriceps, maybe more specifically, although, can't necessarily isolate a particular aspect of the quadriceps, because when you extend the knee, you're working all of them. But there's a focus on the VMO, vastus medialis obliquus. Basically when that lower leg externally rotates relative to the femur, that's going to lengthen the VMO, the fibers of the VMO, which, due to length tension relationships may decrease its ability to produce force. And then when you look at the muscles that cause that particular movement, the short head of the biceps femoris is a big one that can lead to reciprocal inhibition of that VMO as well. And so as you improve flexibility and extensibility of that bicep short head, and you're working to regain control of tibial external rotation and establish more tibial internal rotation, you want to make sure that you're working on getting that VMO to fire up as part of a total quadricep activation strategy. Hamstrings, particularly eccentric strength in the hamstrings, big ones, glute medius, glute maximus, being able to control that femur in the frontal and transverse plane, which is going to minimize stress to the knee. And then, looking at just total single leg stability, and then proximal stability and neuromuscular control of the lumbopelvic hip complex, all going to be really important to focus on as you're getting somebody back to that full performance.
And the one thing I do, a lot of anatomy in that last, seems like 10 minutes, but a lot of anatomy there.
To keep me on track. I told you.
I got to reel you in, Tony. Yeah. So for more information, as far as human movement science goes, I mean, this is an underlying, that's base knowledge that anybody who works with a body needs to understand the body. And I'm learning every day on how the body works. But when you're talking about inverters, rotators, and outside of your biceps, quads, hamstring, all the big stuff, not just knowing what the muscles' names are, but also where they insert and how they interact with other muscles, right? So if we're talking about the lateral hamstring and the short head, short and long head of the biceps femoris, but as it comes down, connects into the fibula, what else is interacting with it? Well, now you have the gastroc, which comes up and crosses the knee and connects into the medial and lateral condyles of the femur. So now you have this interconnectedness between these muscles. So having a deep understanding of not just textbook what these mean, but looking at how they work and function in the real world, so that when you look at the knee, there's a lot of, you talk about the pes answering, you have the hamstrings, you have the quadriceps, and now you have the calf or the gastroc that crosses up and over and down and under each other over that knee. So when you look at function and not just what to do and what needs strengthening or what needs to be addressed as far as overactivity goes, but having an understanding of the body and how things are interconnected is only going to help somebody else when it comes to getting over injury. Because like when you talked about the VMO, well, what's the antagonist to the VMO? Well, you're now talking about the vastus lateralis, if we're just talking geography from that standpoint. So there's a lot on here, but there's a lot that's not on here when you're talking about these other synergists and antagonists to these muscle groups. Yeah. And again, and just a quick point on that. Again, it is in the updated corrective exercise specialist when you talk about human movement science. The chapter on that is actually very impressive.
Yeah, no, great points, Ken. Basically, you're telling me I forgot a few things. So I needed to go like 13, 14 minutes instead of 10 minutes.
All good stuff. All good stuff.
So obviously anatomy, hugely important. That's going to influence, what you're looking at from an overactive, relative underactive perspective. And then when it comes to assessing your client's readiness to come back and assessing their progress over time, that's where you can get into, functional performance testing. And for that, there's a variety of different tests and assessments that are used. One of the primary criteria, again, for returning from knee injuries is, what's referred to as limb symmetry index, where, an ideal value is going to be anything greater than or equal to 90% of the uninjured leg to the injured leg. So basically, if that injured side reaches to at least 90% performance of the uninvolved side, then that's a benchmark that we're looking to achieve. So that can be applied to a variety of different tests. Some of the tests that you may see or that your clients may have had to perform before getting to you, and that could certainly be utilized as a way to progress check and see how your programming is going. Again, the range of motion or mobility tests. You can do isolated strength testing, so looking at hamstring to quadriceps strength ratio. When you look at just balance, that balance error scoring system. Star excursion balance test, where you're looking at single leg stability and how, when they change their base of support by moving the other leg in different planes, what's their ability to control that. We have our transitional assessments: overhead squat, single leg squat. Also, one that's commonly used is a lateral step down test, and there's both a qualitative element there as well as a quantitative element. So you can do a lateral step down where there's actually a checklist, and as the person performs 5 repetitions, you're looking for certain things, and if you identify or observe those, then you would basically knock a point off or add an error to the score. And if the client scores over a certain number, then that would indicate that they have poor control in that particular pattern. But then there's also a quantitative lateral step down test where your client repeats the lateral step down for time, and basically you want to see how long they can perform how many repetitions they can perform that particular movement for within a given period of time. So that's a great test looking at endurance in that lower extremity. And then we get into some of our dynamic assessments, which can be both quantitative, and as Ken mentioned last week, there's a qualitative element too. Not only do you want to look and track time and number of reps or distance, but you want to see how is your client or athlete actually performing during those assessments. What's happening at their foot, their knee, their trunk, and so forth. So some example assessments might be the shark skill test, the landing error scoring system, which is basically a depth jump assessment. Then you've got your single leg hop batteries, where you're looking at a single leg hop for distance. You've got your triple hop, triple crossover hop, and then a 6-meter timed hop. You also have single leg side hop, where you can do hops for time, or you can do repetitions within a given time. Single leg vertical jumps. Then you got your running, sprinting type tests, as well as your agility test. Lower extremity functional test is one that we highlight in our performance enhancement specialist course that is great to utilize. And then there's a variety of other ones, but basically these tests allow you to look at again, compare symmetry between sides as well as progress over time, to see how your client's performance is improving as you dial up the intensity in their programming. Right. So, yeah.
And I'll again, to piggyback onto all those great points, is that we get stuck. When you talk about symmetry, we get stuck. I think as fitness professionals, comparing injured, quote unquote injured, to quote unquote healthy. Right. Mm-hmm. So and this is the one thing, just because the one leg is the one that happened to experience some kind of stress, doesn't mean that the healthy leg is the ultimate benchmark either. Right.
True.
Yeah. Ultimately, we do want to get them closer to each other. So let's say in the case of knee extension, you mentioned 0 to 20 degrees from a 90-90 position. Well, if one of the knees is 50, but the other one is still 30, right? They're still both off, but one's a lot more off than the other. And it's not uncommon to see that even the uninjured leg is worse, goniometrically than the health or the injured leg, right? So there are those opportunities when you look at, someone who's balancing, doing, say, a single leg squat, or just basically a single leg stance on a healthy versus, or the uninjured versus the injured leg. And sometimes because the injured leg has been the leg that has gotten all the rehab,
gotten all the love. Yeah.
They've gotten all the love that it sometimes looks like the healthy knee, right? So I've also seen cases with athletes from that standpoint where the one that looks healthy is actually the one that incurred the injury. So, not to ignore the other side of the body, but we have to look at to your point, the symmetry, the difference between one versus the other, and that could also be relative to like girth measurements and things like that. But also, can we improve the other side as well? Because sometimes it's the deficit on one side that created a shift or a weight shift to the what side incurred more of the load because one side couldn't do its job, so it had to like dump a little bit more work onto the other side, and then that's when you exceeded tissue capacity for stress, and then that's where possibly why somebody got injured.
Oh, for sure. Yeah. And I can think of a particular client that we saw in our facility post ACL rehab and had already returned to play, but was experiencing some residual soreness and discomfort. And we helped him through that, and then stopped coming in, and probably 7 or 8 months later blew the ACL on the other side.
Right.
Just because the focus is on the side that was hurt, and it's easy to neglect the side that quote unquote wasn't affected. So great points. Cool. Well, let's get into some programming. I think one of the things that to kick this off, there's a great the NATA, National Athletic Trainers Association. It's been almost a couple of years ago now. Published a position paper on ACL injury prevention programming. And, there's some general guidelines that and best practices that we can take away from that particular paper that would apply as well to the client that you're helping to return to performance. But one thing that the evidence shows is there's a pretty clear link between, multi-component training programs. So that include feedback. So, coaching, cueing, are extremely important to the process of helping to improve a client's movement patterns, as well as help to reestablish confidence and awareness in that athlete. But multi-component preventive training programs that include feedback regarding technique and at least 3 of the following categories: strength, plyometrics, agility, balance, and flexibility are recommended to reduce non-contact and indirect contact ACL injuries during physical activity, and should be performed at least 2 to 3 times per week, not only throughout the season, but also throughout the preseason as well. We know that multi-component training programs, they're advocated to improve lower extremity mechanics, muscle activation, balance, strength, power, and functional performance measures, as well as decrease landing impact forces. Something that we talked about previously, and we'll talk about again coming up when we get into the specific programming, is that exercises should be performed at progressive intensity levels that are challenging but allow for excellent movement quality and technique. So you don't want to sacrifice technique for intensity. And to maintain the benefits of reduced injury rates and improved function and performance over time, the multi-component training programs need to be performed continuously. And so, speaking, using the client that I just mentioned as an example, when he stopped coming in, he stopped doing his programming that helped him get back to a certain level of function, and he ended up getting re-injured as a result of that. So something that should be performed each year, not discontinued after a single season. And then Ken, you'll probably get into this with the programming, but we also know that these training programs don't have to be performed in isolation. They can be integrated and implemented as part of an overall training program and or other sport related activities. So if you can implement some of these components as part of a dynamic warm up or as part of a comprehensive strength and conditioning or fitness training program. But another key thing is that, regular supervision and focus on technique and movement quality is paramount to the process.
Right. And a lot of what you're talking about as far as increasing the challenge, and all we're talking about is progression. So, I mean, especially in the mind of a highly, somebody who's competitive, right? They're going to want to see progression. They want to see change. Because if all I'm relegated to is a sideline straight leg raise, and I'm going to do that for 6 weeks, and then the variation is you put ankle weights on me, then I'm going to get bored. And if it doesn't, we talked about this last week. If it doesn't look like my sport or feel like my sport, smell like my sport, you're going to lose me. And if you lose me, you're going to lose compliance as well. And I think, experientially, it's you have to dive into what it is, their sport, and have whatever progressions that you integrate into their programming reflective of what they're working towards. So if we first start off with a floor bridge and then we turn that into a bridge with a march or a single leg floor bridge, or a bridge with a push and pull, just to add some variety and challenge to the hip, you got to not just have progressions, but also variations to that standpoint, because, as we're talking about, it has to be done before the season starts as well as in season, because, that what it took for you to get healthy is what it's going to take for you to stay healthy. So now, I mean, you're a different machine after injury, and to get past and to progress. So if you're a high school kid and you want to compete at the collegiate level, whether it's club or for the school, then you're going to have to do more things than somebody else when it comes to just having to keep the integrity that you've worked so hard to get, but also, I mean, your body's different now, and you're competing at a even higher level than where you were before. So no one just wants to compete at the same level, right? For those people that I have in mind right now that are competitive just in their own mentality and in their persona. So from there, it's just, you have to keep interest, and interest is kept by showing progression, right? If they're improving their body, they're improving their play. Is what I like to kind of, the motto I like to throw at them.
Love it. Yeah, absolutely. Yeah, that variability is so important as well. We think about progressing individual exercises, and that's one piece of it. But varying the types of exercises, that variability is what leads to adaptability as well. So super important. I think, and you just alluded to this, but when it comes to individuals, all individuals involved in sports and physical activity, it's advisable for them to participate in a multi-component preventive program. However, with that said, those who are active in particular sports, let's say, those that involve landing, jumping, cutting tasks, field sports, basketball, court sports, particularly young female athletes should be targeted specifically for injury prevention training, just because they're either at a relatively higher risk for ACL injury, or they may be at a greater potential for benefit, right? So if they're, I think that speaks to what your motto, if you're improving your body, you're going to be improving at your sport and your performance. And then as mentioned before, previous injuries, the biggest risk factor for future injury. And so anybody with such a history should be a target for that type of programming. And it needs to be integrated into their overall program. So, with that, let's get into some programming. What do you got?
Going back to the anatomy lesson that we had earlier in this, in this call, just figuring out, okay, just getting to the hamstrings is a big one, or let's say may not be the end all be all, just because, based on what the hamstring, where it is and what it does. I mean, it's a very influential area. And it's one of those conversations that I have a lot more often with parents. Parents always talk about hamstring. When I do have these conversations with parents, no one ever really talks about quad as much as hamstring. That may be a different experience for you, Tony, but I like to bring up the hamstring just because of how it does influence a lot of what we just discussed as far as the knee valgus issues that may pop up. Excessive anterior pelvic tilt, things like that. So when it comes to the inhibition standpoint, the foam roller or some kind of inhibitory tool is going to be a big part of how you prep for movement, as well as warm down after post activity. So getting into inhibition, just as a summary of what we discussed, the corrective exercise strategies, you want to free up motion first. So if there's a particular joint that you need to emphasize as far as, okay, well, what's restricted and what do we need to increase as far as range of motion goes, because it's one of those things that my dad taught me early is like, if it's supposed to move and it's not moving, what do? WD-40. And if it's moving and it's not supposed to move, you have duct tape, right? So those two things. So here we have, inhibition. So we have to get the muscles to relax. Through that, autogenic inhibition, getting the muscle to relax with sustained pressure. And again, it can be facilitated different ways depending on the modality that you're using. So whether you're using just a static roller or something like the Hyperized Viper, which now incorporates vibration and can help elicit not just a relaxation response, but an altering or a changing in fluid dynamics that can help improve range of motion. Because and I know you've seen it, Tony, to where if I can inhibit or get somebody who's showing me 40 degrees on a goniometer for their 90-90 knee extension, I'm not surprised if I get 10 to 12 more degrees just by foam rolling itself, right? Mm-hmm. So if I can get more degrees of freedom from, in that example, the biceps fem, if that's the area I'm going to emphasize, to get better knee extension, which again contributes to triple extension, relative to sprinting and jumping. Now I've allowed the joint to open up, which now allows better recruitment of the opposing muscle group. So the first thing, relative to, again, it's all going to depend on what the assessment results are going to show you, right? So if the knees are coming in, I'm going to look at, the outer hamstring. I'm looking at the TFL. I'm looking at the piriformis, right? So working on the glutes, the adductor complex, outer hamstring, outer lower hamstring, and the outer calf, the outer gastrocsoleus complex, just to kind of simply put, and just to pick on one compensation. But another point that we also brought up last week is that as far as compensation goes, it's never just one compensation and nothing else exists, right? They're usually compounding, or what I heard one of our other instructors call, a layering of compensations, one above the other. So when it comes to observing the assessment results, whatever the assessment may be, overhead squat, single leg squat, just to pick two, then I'm going to pick which one is showing me, the most gross deviation from what we might consider normal.
Yep.
So as far as the inhibitory effect of corrective exercise, that would be the first thing, and it's usually the easiest thing to address because you're leaving it up to the athlete or the client to, okay, you find your spot, or you tell me where you're experiencing a little bit more tenderness, and then that's the spot you're going to hit and stay on until that area relaxes. So to pick on the knee, a lot of times, whether it's assessment driven as far as the muscles that I pick, or if they just happen to be exploring other areas and then they experience tenderness. The aspect of, foam rolling or self-myofascial technique itself is an assessment as well. I don't think we brought that up last week.
Mm-hmm.
And then, I don't know, anything else to add on to that first step?
No, man, that was awesome. That was great.
Yeah, and it was, wasn't it? So the other part of it is now to
mic drop. Mic drop time.
Yeah, mic drop. I'm out. Now getting the static stretch to complement what it is that you just relaxed, or you allowed that relaxation response, and now it's time to take advantage of that relaxed state or that greater range of motion. You're not going to get the resistance as much now if you were to incorporate the static stretch. Although if somebody or an athlete, due to some condition or another, is not qualified, or it's a contraindication to use self-myofascial techniques, you're just going to have to go straight into static stretching to address the length limitations when it comes to a particular joint. So from that standpoint, getting into standing calf stretch, if it happened to be a coinciding lateral gastroc-soleus overactivity vantage point, or standing adductor stretch, which winds up being a big part. But a hip flexor stretch winds up being a pretty vital component. And again, in the context of adolescence, here we are at this point in time, everybody's homeschooling and they're spending more time behind a computer. They're not up and active as much. They're not walking between classes. So they may spend more time behind a computer or screen. So just, looking at life as it relates to sport and activity, they are in a more hip flex position. So opening up the hips to allow greater hip extensions, which allows the knee to do what it needs to do from a flexion extension, and not necessarily, have a hamstring that's under moving and now restricting motion from more proximal versus a distal vantage point. So flexibility routine, again, specifically to the adolescent, we in school and wanting to run and play, you need to look at both what's happening outside of what they're doing in sport to figure out from a program design standpoint what can be or should be implemented to account for the whole person and not just the sport. Which is what we tend to forget as personal trainers or strength coaches. We just think about, okay, what are you going to do when you're playing, right? Not necessarily what you're doing the other 22 hours out of the day that we need to look at. Anything else on that, Tony?
I think flexibility? I think one area would be the adductor magnus specifically. The adductor magnus is less of an adductor. Particularly posterior fibers or posterior head of the adductor magnus, along with that long head of the biceps femoris, can limit hip internal rotation, which we certainly want to address. So if you see that in your mobility assessments, you see that limitation in hip internal rotation, that adductor magnus could be an area that you'd want to focus on with your flexibility, inhibit and lengthen strategies. Because that can have a direct impact on the knee. And then I can't recall if you said it or not, but the calf complex, again, if you've determined that ankle mobility is influencing what happens at the knee, that's going to be a big one as well.
Yep. And the one thing for personal trainers out there, don't be surprised. And this is where things get cut short when it comes to the rehab process, is that you'll have clients and athletes that feel better just by getting range of motion. So if, sometimes the mentality is, and the conversation I have to have with just clients in general is that, you've got this range of motion and you've decreased the stress at a given area, and that's awesome. However, now you have all this, what we call, or can consider, naive range of motion. You have all that range of motion, but your brain and your body doesn't know how to coordinate it, doesn't know how to control it. And from a muscular control standpoint, if you're not confident, if the brain or how you strategize, movement, if there's lack of confidence in you getting so much range of motion, it's just going to take it all back. So this is where now getting into the next steps, which is now the strengthening component of program design is important, because they sometimes, just because they feel better, they think that's all they need, and flexibility is the key. But unless you teach the body how to use that range of motion and control that range of motion and be strong with that range of motion, you're going to lose it again. Because as I'm sure you've heard millions of times, is that I stretch and I stretch and I stretch, but I'm still tight.
Yeah.
Whatever tight means, right? Well, you stretch, you try to get all this length, but you try to use it, and your brain says, we're not going there, because you're going to get hurt with all that extra, degrees of freedom. So the next step being strengthening some kind of activation or upregulating of how we use the muscles. So now, again, the knee being the dumb cousin to the hip above and the ankles below. Now I've got to teach the foot and ankle how to be strong and stable, or stable and strong. And I got to teach the hip to do the same thing, so that now, with whatever freedom we've given to the knee or the hip, depending on what dysfunction is showing itself, you've only got half the picture, right? You've got the outline, but we haven't colored anything in.
Yeah.
Yeah.
So what'd you do from a strengthening standpoint? What would you recommend in this scenario, Ken?
Yeah. So from that vantage point, it is about, strengthening up, all the foot inverters, whatever the assessment goes. Again, this is a lot bigger conversation when we start talking about specific compensation patterns. But that's where the solutions table that's provided on the NASM website definitely comes into play to help you understand, okay, well, what are some options to help activate those muscles that have not been doing their job? But the quick and easy hitters are, basically the glute complex. So I mentioned the sideline straight leg raise is a big one, because, I've had 300-pound linemen that just the weight of their massive thighs alone was enough to where, you get 4 reps into it with a 3-2-1 tempo or 4-2-2 tempo, they're sweating, right? Because now they have to lift the leg, right? They have to laterally raise the leg, but I'm telling them to, keep that spine in a neutral position, pull in the belly button a little bit, just show me you've got some control over that midsection. Now raise that leg, and they are sweating, right? They're like, they're raising their leg like maybe 3 or 4 inches, right? And that's enough. So the sideline straight leg raise winds up being, a lot more challenging if you're going to do a full 15 to 20 reps at a very slow tempo. And then, of course, you have your bridge and your bridge variations, right, to help with hip extension. So, things like that. If you're talking about the VMO, terminal knee extension, or TKE, as it might be abbreviated from a physical therapist, if they are handing off to you as a strength coach or personal trainer. So, that's just, the end range of knee extension to strengthen up or put more emphasis on that vastus medialis oblique. So to pick on 3, areas, or 3 muscle, or pick on exercises would be the ones I see most often when it comes to reconditioning of the knee specifically. What else would you add? I know you've got a lot of experience with that as well.
Yeah, no, that's I'm right there with you. And I think, one of the things we mentioned is progressing programming, but there's also there also may be a need for regression, right? So you mentioned the linemen who can only lift their leg 4 or 5 reps before they compensate. You may have clients where you might need to regress that particular exercise, and so a regression might be like a clamshell. Or maybe you change their body position relative to gravity, where they're doing a resisted abduction exercise, prone or supine with a different type of resistance. We tend to get caught up. Well, this particular exercise showed greatest EMG activity in a particular study. It doesn't make the other exercises that didn't have the highest EMG activity completely ineffective, right? So just because a clam
Right.
maybe doesn't have as much EMG activity as a sideline leg raise when it comes to the glute medius, it still may be a better option for that client to be able to execute with optimal form and technique and endurance. And then you progress them to the sideline leg raise once they establish competency and the ability to do what you need to do. So just keep that in mind as well. We talk a lot about progression, but make sure that you are looking at regressions when appropriate. And then, specifically, I think the hamstrings, if you were going to target the hamstrings, those tibial internal rotators. So again, just reinforcing, eccentric hamstring stiffness. So the ability to decelerate knee extension. There's a synergistic effect there. If we're looking at, let's say, the ACL in particular, synergistic effect with the hamstrings in that regard, and being able to provide some protection of the ACL. And then modifying the foot position to bias the tibial internal rotators. So, let's say you're doing a stability ball leg curl. You can turn the toes in slightly to get more of the semis versus the biceps femoris. Or if you're progressing your client to Nordic variations, changing the amount of hip flexion, changing the foot position is all going to influence the activity of certain muscles. And so depending on what your assessment shows and what you feel your client needs to work on, those are all modifications that you can make to the technique in order to get the outcomes that you want. So, and then just core stability overall, just proximal core stability has been shown to be very effective in helping to improve and improve lower extremity alignment and control during functional tasks. So, just kind of looking at the entire system. But yeah, that's all I've got there. So then what do we get into?
Then integration, right? And you're just kind of putting it all together. And since we're talking about return to performance, it's not just about what you might see in a lot of NASM's collateral or their content, where it's it's a balanced exercise, especially when we're talking about corrective exercise or even stability training. But because we now have to consider the sport that the person is playing or participating in, now we have to have it. This is where we start to make it look, feel, smell like the activity that they're trying to work towards. So when it comes to an integration, we're typically would talk about, let's say, something like a side lunge to balance, or say starting off even more remedial than that is a balance and a lateral reach. So if I'm trying to recruit more of my hip abductors, right? So if I'm trying to incorporate more of my hip abductors, so it's a single leg balance with a lateral reach, I'm just reaching out to either 3 o'clock or 9 o'clock, depending on, which leg I'm using. So, that's where we might start. But from that standpoint, that might turn into a balance and step, right? Balancing on the right side, then balance there, then step to the left. So now we start to incorporate a little bit more of a transitional, recruitment pattern, just going left to right, maybe for incremental timeframes like 10 seconds, work from just a balance at maybe 30 seconds, decrease that to 20 seconds before you shift onto the other side, 10 seconds, shift to the other side, 5 seconds, shift to the other side, and just gradually decreasing the amount of time of balance and then increase. So now, therefore, you are increasing the amount of transitions left to right. Again, that's progressing over time, but just to give you some insight on how that might look, maybe it's Monday is we're just a single leg balance for 30 seconds on each side. And then Monday of the next week, and that's their homework, right? So Monday of the next week, it's a single leg balance for 20 seconds, but now shift onto the other side. So now you're adding a transitional component. So when we take that integration from that corrective exercise strategy as NASM teaches it through its protocol, now to perform better, now we have to make moves that get them in positions and teaching them stability or isometric stability and eccentric loading into positions or directions that they may typically move into during their play. So if you're a shortstop, right, we want to work on more lateral motions, or if anything, turning 270 degrees, turning around and changing direction that way, and adding that into the, let's say, a balance component. So, again, when you look at the continuum, slow to fast, adding complexity as the person earns their way. But one point that we did not make last week, and something that I do incorporate when I do work with athletes that are coming back into play, is the fact that if there's any kind of association between the movement that they're doing with pain, we again have to put on our training hats, and we might have to be creative in that we have to figure out ways, when we talk about variability, of getting them to move into positions or directions and at speeds that don't provoke pain as well, right? Yep. So, and that's what's going to affect recruitment, not just, I don't want to go there, but the brain's going to have some affinity to going in certain directions at certain speeds from certain body positions. So, and that's a concept I picked up from our buddy Anthony Carey down in San Diego. It's like, you want to incorporate movements and patterns that aren't provocative to the association with pain either, right? So not just about how to recruit or what to recruit, but it's also getting them to move with confidence without previous association with what it was that possibly got them hurt, or whatever their brain associates with. Okay, I got hurt doing this last time, right? Or I was in this position last time. Well, I don't want to be in that position this time, so I'm going to avoid it altogether. So kind of tricking, the person how to get there without going there, so you're just kind of doing a roundabout. So integration and strengthening exercises, how we incorporate recruitment and movement strategies, has to be just built up gradually, but also we kind of have to watch out for those caution flags, of what somebody might affiliate with, how they got hurt to begin with.
Yeah, no doubt.
Yeah.
Cool. And then, once you've progressed that integration step, you get more into performance oriented drills and the like, what would you do in that sense? What are some things that you would address?
As far as, getting them more into performance, if I can get them, for one, if we're talking about, speed, agility, and quickness, getting them into the environment. So there's been time, there's a park nearby where I've taken my athletes outside. So if they play on grass, I'll get them on grass. So to feel the different texture, just the smell of grass, just to get them, to see the light at the end of the tunnel. But, to get them into that environment, whether or not, we're still doing regressed exercises and strengthening program, just to get them to that environment, get them into the psychological mode of, okay, well, now I can play, right? But, implementing, just like what we talked about last week, what's the gear that they need? What are the tools? What kind of, am I using a lacrosse stick, a lacrosse ball, a football, a soccer ball, a volleyball, things like that. Not saying that if I'm working with a swimmer who's got knee issues, I'm going to splash water on them, but I just want to get them to get and have the same feel for what it is that they're doing. So if it's a soccer player or a kicker, get them used to doing some, maybe, some balance work with that cross rotational pattern of that kicking, their dominant or maybe even non-dominant kicking leg, along with having some kind of, contrary motion or opposing motion and rotation through the upper body. So, that's just an example. So I just wanted to start to look, feel, smell like what it is that they're doing. And one of the first things I do is implement the tools or the implement that's involved with the sport that they play. Yeah.
That's great.
That's a start.
Cool.
Right. But one more thing is if it's a matter of if there's contact, adding perturbation. So I might tap them lightly on the shoulder or the hip, or from different directions while they're performing a certain drill. So getting that stimulus that helps create that ability to react and dynamically stabilize when they're doing something as well. So if it's a high contact sport, that touch is going to greatly increase over time. A lot of people don't realize how much contact is in basketball or in soccer. So there's going to be a lot of perturbation or added, unanticipated contact. Again, within reason, and of course, you have to be responsible with that. I'm not going to blindside somebody and give them a forearm to the throat. But I'm gonna give them something to think about when it comes to, okay, this is what it's gonna look and feel like. Just a little reminder, especially if they've been out for a season or something like that, or if they've had a long rehab process, just to get them reacquainted with what their body's gonna go through from a reactive standpoint.
Yeah, no, absolutely. And to that end, those are things that you can do with some of your lower level integration exercises as well. Just to enhance that reactive neuromuscular control. If somebody's doing a single leg RDL or single leg squat touchdown, step ups, hops, if they're on a slide board, you can initiate some of those perturbations to be able to get them to react and respond appropriately.
Exactly.
Yeah. Okay.
All right.
So anyway,
there's lots to chew on there.
Yeah, there is. So I think that might be a great place to stop.
Yeah.
Awesome stuff, and I certainly learned a lot. Always do when I'm talking with you, Ken.
Same way here, man.
To those of you listening, as we mentioned at the top of the hour, any questions, comments, please leave them for us below, and if we don't get to them in real time, we'll address them at the top of the next episode. So, as always, thanks so much for tuning in. We really appreciate you and the opportunity to interact with you. So, Ken, thank you so much.
And thank you, Tony. Great time.
Yeah, look forward to next time.
Yes, sir.
Take care, everyone.